think one of the important things to keep in mind with extensive stage small cell lung cancer is this is a disease that moves quickly, and we really need to minimize delays. We know from early placebo-controlled trials in the 70s that without treatment, the average survival would only be a few months. And so we need to really institute systemic therapy as quick as we can. As a result, a lot of the patients that we are treating for small cell lung cancer don't perfectly fit the clinical trial population. Patients may not have a perfect performance status. They may not have treated brain metastases, but we need to move forward lest that disease really go too quickly and we lose the opportunity to institute therapy. With platinum doublet chemotherapy, we see fairly high response rates, at times even complete responses. The problem has been that these responses are transient. And as much as we expect a response, we expect patients to feel better, we also expect relapse. Small cell lung cancer responds to any number of agents up front, but that response is transient, and when the cancer relapses, then it is highly refractory to most of our standard treatments. So our standard, since the 80s at least, has been platinum etoposide chemotherapy for small cell lung cancer, and we have not been able to improve upon that regimen. But it's not for lack of trying. There have been many failed phase 3 trials for small cell lung cancer. You can name up to 40 different trials. Over 60 different drugs have failed to improve the standard of care. And we've tried many different strategies, alternating back and forth between regimens, high doses of chemotherapy, novel combinations, anti-angiogenesis. The list is very long. And what we are sometimes able to do is increase the response rate, improve progression-free survival, but not really impact the history of the disease. We haven't been able to improve survival. My current approach for extensive stage small cell lung cancer is a combination of carboplatin, etoposide, and atezolizumab, the anti-PD-L1 antibody. And that is concurrent use from the beginning, followed by maintenance atezolizumab until progression or loss of benefit. This is based on the Empower 133. This is a randomized phase 3 double-blind placebo-controlled trial where all patients receive standard carboplatin AUC5 plus etoposide 100 milligrams per meter squared days 1 through 3, and were randomized 1-to-1 to receive concurrent atezolizumab or placebo during chemotherapy after 4 cycles, then maintenance atezolizumab or placebo. And what the study showed, for the first time in decades, is that the addition of atezolizumab, this intervention, this addition of upfront immunotherapy, improved survival. And so we had a median survival of 12.3 months versus 10.3, which is a hazard ratio of 0.70, a 30% reduction of the risk of death. Importantly, that survival benefit did not come at the cost of significant toxicity. The rate of grade 3-4 adverse events were similar between both arms. Most patients were able to complete 4 cycles of chemotherapy. The survival benefit didn't compromise our ability to complete chemotherapy. And with that improvement in survival, we finally advanced the field, and it's really been my approach. What we've seen with other trials is that the use of second-line immunotherapy, nivolumab versus topotecan, did not improve survival, checkmate 331. We saw maintenance therapy with nivolumab, ipilimumab right after chemotherapy, not waiting until progression. That maintenance strategy also did not improve survival versus placebo. The only strategy that's been shown to improve survival is the upfront addition of an anti-PD-L1 inhibitor with first-line chemotherapy. And so these delays run the risk of forfeiting that survival benefit. Some of our first experiences with immunotherapy in extensive stage small cell lung cancer were in the relapsed and refractory setting. And what we saw is previously treated patients with small cell lung cancer who received nivolumab monotherapy had a response rate of about 10%. When you add the CTLA-4 antibody, ipilimumab, you double the response rate to about 20%. You do also increase toxicity. We see comparable response rates with pembrolizumab monotherapy in the third-line setting, about 19%. And these response rates are modest. And if you look at median progression-free survival, they're quite poor, somewhere between 1.5 to 2.5 months with any of those regimens. But what we see with those treatment options with immunotherapy in the third-line setting are durable benefit, our extended survival, our landmark survival rates that are much higher than we would expect. With nivolumab and ipilimumab in checkmate 032, we saw a 2-year survival rate of over 25%. And so while the medians are not too impressive, the landmark survival rates are quite impressive. And in the third-line setting, to have more patients alive at 18 months at 2 years really is quite remarkable. And it led to the approval of nivolumab and pembrolizumab as monotherapy in the third-line setting, an accelerated approval based really on the durability of that benefit and the extended landmark survival. Moving those drugs to the second-line setting, though, has proved challenging. And nivolumab versus topotecan in checkmate 331 did not prove to be superior. And so we don't have a viable option over chemotherapy in the second-line setting. In the maintenance setting, nivolumab, ipilimumab versus placebo did not improve survival. And so we have drugs approved in the third-line setting, really filling an unmet need. In the second-line setting, our standard of care would remain chemotherapy, and the only FDA-approved agent there, topotecan, but certainly an unmet need for more novel agents there. And as we move immunotherapy into the frontline setting, then the second-line option has to change, and that space is still evolving.